First, scalp and skull fractures. Second, brain trauma triage rules. Third, primary brain injuries. Fourth, intracranial hemorrhages explained. Fifth, secondary injuries and ICP. And finally, patient outcomes and brain death.
Let's dive right into Section 1, Scalp and Skull Fractures.
Starting at the very surface, have you ever noticed how much the scalp bleeds when it's cut? It's crazy. Well, that's because the connective tissue layer contains these fibrous septi that the blood vessel walls actually stick to. This totally prevents the vessels from constricting normally when they're lacerated. So out in the field, your very first step is super simple: apply pressure. But in the emergency department, when an intern has to actually suture a scalp laceration, well, the skin there is incredibly thick. If you use a standard round body needle, it's literally just going to bend or snap. You absolutely must choose a tough cutting or reverse cutting needle and pair it with a thick 1/0 or 2/0 silk or nylon suture.
Now here are your absolute clinical cheat codes for base of skull fractures. It's fascinating how distinct these are. For an anterior fossa fracture, specifically the cribriform plate, you're going to see raccoon eyes, those classic black eyes. You might also notice clear fluid leaking from the nose, which is CSF rhinorrhea. And you can actually confirm it's spinal fluid and not just a bloody nose by looking for the target or halo sign on a piece of blotting paper. Moving on, middle fossa fractures involve the petrous temporal bone. Here you'll spot the battle sign, which is a bruise right behind the ear over the mastoid process, along with a really strange phenomenon called paradoxical rhinorrhea. That's where CSF actually pools in the middle ear, travels all the way down the eustachian tube, and leaks out the nose. Finally, posterior fractures of the occipital bone show up as sixth nerve injuries or Vernet syndrome, which affects cranial nerves 9 through 11.
All right, moving inward. Section 2, brain trauma triage rules.
When a patient hits the ER, the Glasgow Coma Scale, or GCS, is a total cornerstone of triage, but the timeline for monitoring it is extremely strict. For those first 2 hours, you're checking it every 30 minutes. From 2 to 6 hours, it's every single hour, and after 6 hours, it moves to every 2 hours. It is absolutely crucial to track the trend of that GCS accurately over time. You can't just lazily copy the first value from the previous chart, because a falling GCS is a massive red flag.
So, the crucial point here is the overlap in symptoms that tell you when you must urgently order a non-contrast CT, which, by the way, is the absolute investigation of choice, and when you actually need to wake up a neurosurgeon. Shared indicators include things like loss of consciousness, seizures, throwing up more than once, any end bleed, or any focal neurological signs. But pay close attention to the specifics. If that GCS is 8 or less, or if the patient has unexplained confusion lasting more than 4 hours, a neurosurgeon must be consulted immediately.
Let's go a bit deeper. Section 3, primary brain injuries.
Let's look at the mildest type of primary brain injury, the concussion. We quantify it using the Colorado classification. Notice how it progresses. It starts with type 1, which is just simple confusion, moves to type 2, amnesia, and finally hits type 3, actual loss of consciousness. Now, a non-contrast CT for a concussion is going to look completely normal. We see this mild primary injury all the time in contact sports, like rugby or cricket. The immediate fix? Just take a break from the sport. But beware, because repeated concussions can cause a devastating long-term condition called chronic traumatic encephalopathy, or CTE, which presents with severe behavioral changes down the line.
On the total opposite end of the spectrum, we have diffuse axonal injury, or DAI. Unlike a concussion, this carries the absolute worst prognosis among primary brain injuries. It's caused by a massive shearing force that literally tears the brain's gray and white matter apart. The classic, terrifying presentation is a comatose patient whose GCS just isn't improving. Yet tragically, their non-contrast CT scan looks perfectly fine. To actually see the damage, you have to get an MRI, which will show these tiny punctate hemorrhages, usually right near the corpus callosum. This is actually the exact type of injury Formula One legend Michael Schumacher suffered during his skiing accident, which left him with profound, lasting deficits.
Moving right along to Section 4, intracranial hemorrhages explained.
While a contusion is the most common brain hemorrhage, what's really interesting and critical is how we distinguish between the two major life-threatening hematomas, extradural and subdural. Think about the explosive, high-pressure arterial nature of an EDH. It's usually seen in young people after a high-velocity impact that ruptures the middle meningeal artery, forming a distinct biconvex shape on a CT scan. Compare that to the slow, creeping venous leak of an elderly patient's SDH, which can happen after a totally trivial fall. That SDH comes from tearing the cortical bridging veins, and it creates this crescent, concavo-convex shape right between the dura and arachnoid layers.
And you've got to beware the devastating lucid interval that's so often tied to an extradural hemorrhage. This is a terrifying period of totally normal consciousness, sandwiched right between two episodes of being knocked out. Imagine a young naval officer who gets into a minor motorcycle crash. He loses consciousness, wakes up, feels totally fine, goes home, starts cooking dinner, and then, out of nowhere, collapses and dies, simply because that arterial bleed silently expanded and crushed his brain.
But what if you don't have a CT scan handy? Well, normally you'd localize an EDH by drilling a burr hole on the side of the dilated pupil, but watch out for the Colonel Hens notch phenomenon. This sneaky little issue creates a false localizing sign. Say you have a left-sided hemorrhage. It can cause the temporal lobe to herniate, but that herniation pushes the brain so far over that it actually compresses the right corticospinal tract against the tentorium. Since our motor tracts cross over, this results in left-sided weakness. So you see left-sided weakness, and it totally tricks you into looking at the wrong side of the head for the source of the bleed.
Section 5. Secondary Injuries and ICP.
So what happens when the pressure inside the skull reaches its physiological breaking point? That terrifying reality is governed by the Monroe-Kelly doctrine. Basically, think of the skull as a rigid, unyielding box with a fixed volume holding your brain, your CSF, and your blood. If a new mass shows up, like a bleeding hematoma, the brain initially tries to compensate by pushing out CSF and venous blood. But once it runs out of extra space, wow, the pressure doesn't just rise gradually. The intracranial pressure skyrockets in a sudden, steep spike, which leads to fatal brain herniation.
To survive that intense pressure, the brain still desperately needs blood flow, meaning it needs a high cerebral perfusion pressure. To force blood into a highly pressurized skull, your body triggers what's called the Cushing reflex. It aggressively cranks up the mean arterial pressure, causing profound hypertension. And because the heart is stretching so much to pump that hard, the heart rate actually drops, causing bradycardia. Throw in some altered breathing, and this life-threatening triad is essentially the brain's desperate final attempt to keep itself alive and oxygenated.
So when you're managing this raised intracranial pressure on the ward, your main goal is to keep the systolic BP over 100 to ensure perfusion. But remember this one unbreakable rule: strictly no dextrose fluids. Dextrose actually worsens cerebral edema and can trigger hypoglycemia, both of which are disastrous for the brain. Instead, you want to rely on normal IV fluids and a hyperosmolar drug like IV mannitol to literally draw the excess fluid out of the brain tissue. You can also use moderate hyperventilation. And as for steroids, while they work great for tumor-related swelling, they have absolutely zero role in traumatic head injury. None.
Finally, Section 6, Patient Outcomes and Brain Death. Once a patient actually stabilizes, we have to look to the future. Now, make sure you distinguish this Glasgow outcome score from the coma scale we used earlier. This is your prognostic tool to map out the rest of a patient's life following head trauma. A score of 1 means death, 2 is a persistent vegetative state, and it moves all the way up to a 5, which means they've made a good, functional recovery.
Tragically, if a patient just does not recover, we have to know when further intervention is futile. To officially diagnose brain death, a patient has to meet some incredibly strict criteria. We're talking a rock-bottom GCS of 3, totally non-reactive pupils, completely absent brainstem reflexes like the gag or corneal reflex, and 0 spontaneous breathing effort. Crucially, you have to rule out confounding factors like profound hypothermia or drug intoxication. And just to be absolutely certain, 2 independent clinicians must verify every single one of these criteria.
The line between a minor concussion and a fatal secondary injury is razor-thin, isn't it? When you're managing these patients, the cascade from a simple skull fracture to skyrocketing intracranial pressure can happen literally faster than you can blink. It leaves us to wonder, just how prepared are you to act when every single second counts? Thank you so much for joining me on this explainer, and definitely keep these cheat codes sharp for your clinical practice.